and she was working as the chief editor of Indian Journal of Palliative Care, which is the official journal of Indian Association of Palliative Care. And she has a lot of experience in teaching and a good friend of Pallium India. So thank you, madam, and welcome you, and it's over to you.
Thank you, Dr. Sunil and Shri Priya. The first communication class I ever heard was by Dr. Rajgopal, and that was after I had been an oncologist for 10 years. I think for most of you, you would hopefully have heard by now. I am audible and visible, I hope.
Yes, madam.
Yeah, and in case we get into any difficulty with the videos playing, I hope you'll be able to share from your end if I get stuck here. I also just wanted to check the case presentation. Normally, when do you have it? Is there a set time, or can
it's
we?
after 1 hour. So
After
now it's
1 hour.
yeah, at 7 o'clock. We can start the presentation.
Okay, sure. I have only a few slides. Mostly I have videos. Now, Dr. Sunil and Shri Priya both said that communication is very, very important. So let me begin by just telling you a small true story. Like in our hospital in Vellore, we get patients from many parts of the country. So one day in our hospital bed in palliative care was an elderly man with stage 4 stomach cancer and his wife. And then when I looked through the notes, I realized that about 1 year earlier, they had come to our hospital. And at that time, they had spent a couple of weeks being diagnosed. And they found an operable cancer. And then after that, they went away. So then I asked them what happened after doing all this. Why did you leave? So apparently, the person who had gone to speak to the doctor was a broker who was an interpreter. And when he heard it was cancer, he decided cancer means it's not curable. So he told the patient and the family that you just need to take these tablets and you can go home. So after the correct evaluation, with the correct plan of management, still a life was lost because there was a communication gap. Somebody has said that an act of communication can be a life-saving intervention. And that is really, really true. Okay, so let me try and go to my first slide. Oh dear, there we get stuck again. Am I a co-host? It's not allowing me to share.
Yes, ma'am, you are already co-host. We have already given you access.
Yeah. Okay. Yeah.
It is visible now.
Is it visible now? Yeah. So first, let's have a little vote. Which is more important, the clinical history or the physical examination? Both are important, that we know, but which is more important?
History, ma'am.
Yes, the history. Can we have a few more answers? Yes, we have it on the
clinical
chat.
history.
The clinical history. Why do we say that?
If it's taken correctly and with patience,
Yes.
it can provide a lot of clues. So it's like what the mind doesn't know, the eyes can't see.
Yes. Okay.
Adds more of
Thank you.
patient's perspective also, ma'am.
Yes. Can you elaborate on that?
Ma'am,
So what you said about,
if
Dr. Jagrati has written to know the person rather than the patient.
right, yeah, Dr. Sunil, for some reason I'm not able to see my chat. So if someone says something, could you just
Yeah, yeah. And Dr. Biju says it gives a roadmap for further management.
yes,
Dr. Raju says history is necessary even to interpret the physical findings. Dr. Emmett says it helps the caregiver to understand the concerns of the patient.
There are
fantastic.
lots of things we get to know when we take a proper detailed history. Even the way the patient is speaking, that also gives a lot of information about the patient's emotional condition. And like generally, the thing which is troubling them most, they will give more emphasis on those things and such kinds of things.
yeah, we know what.
Dr. Vasanta Kumari says patient tells his diagnosis in history.
I think we have some
There is
absolutely.
one more thing
Ah,
I would like to add, that
yes.
a physical examination will generally give an idea of the physical ailments or what is the physical manifestation. But a history will also give emotional manifestation, the what ramifications got on the psychological, along with the physical. So it gives the idea of the total impact of particular diagnosis on the patient. And that is why I think history is very important.
Brilliant. I think
Dr. Ravi says history gives us a chance to establish communication with the patient.
Ma'am, there are some non-verbal cues also which can be picked up while you're communicating.
yeah. So I think you've given all the key points and put them very brilliantly. And the term roadmap, for example, I also like that metaphor because if we don't take a holistic history, it's like going in with our mental bias. For a neurologist, every pain will have a neurologic cause. As an oncologist, every pain will have an oncologic cause. We will go down the most comfortable exit from a roundabout. And on a highway, if we take the wrong exit, it takes a long time to come back. And for the patient, this means at worst, it may mean that they may die of a wrong diagnosis. At best, it may mean they may waste some time and money. And like you said, the physical examination may tell us about the disease, but the history also tells us about this person's disease and what they want. Okay, so let's look at our first video and um, tell me how this doctor could have taken a better history. The first few minutes are a little soft, then it gets better. What would you do to take a better history? 1 or 2 points.
Firstly, start with the uh, building up the rapport with the patient, and go to the like start with the present complaints and the details about the present issue first, and then rest of the things. And we should directly ask the patient and things, and then later on make down our notes. It's like looking like the person is just taking some survey or something like that. And in that scenario, patient will never be comfortable to give the details which are exactly important in the history.
Yes, sir. Thank you. You've covered several aspects. And
I would like to share
Yes.
something.
Yes.
I am Dr. Priya. This is a personal story, nothing against anything.
Yes.
But this video made me relive something which I had undergone around 12 years back. I
Uh-huh.
had for a gynae examination in a reputed hospital. And scene by scene, I had a similar thing where I was put on the stirrups and then the person went off and then they came off after half an hour with me. And I still remember it. So I totally understood what the lady was going through because it was such a mechanical way of taking a history, especially since he knew that lady and she was his teacher. So it was totally bereft of any connect.
Yes. And whoever it was, even if it was not his teacher,
Yes.
the how it feels to be at the other end is very, very difficult.
Yes.
Now, you've given me some nice answers in the chat box. Let me try one small exercise. Okay, and maybe I'll ask you, Dr. Priya. Okay, I'm just going to, I just want to get some information from you. Very simple information. Um, Dr. Priya, this morning, did you have pizzas for breakfast?
Did I have what?
Pizza for breakfast?
No,
Did you have chana bhatura for breakfast?
no,
Did you have appam for breakfast?
no.
Did you have puris for breakfast?
No.
Okay, now, what do you guys feel about my history taking of Dr. Priya's breakfast? How could I do it better?
Could have asked an open-ended question. What did you have for breakfast?
What did I have for breakfast? Huh? Actually, what did you have for breakfast, Dr. Priya?
I had some green vegetable with chapatis.
Right, okay. I don't think I would have got there even with quite a
Exactly.
long checklist.
Yes,
Uh,
yes. I
And
think that's a
sometimes,
problem
especially,
with the checklist.
isn't it? That is part of the problem with the checklist. And sometimes, when I ask people, say, "Oh, I didn't have breakfast at all. I was on duty at night and I came running to work." So, the thing about starting with very closed questions early on is that, uh, we can, first of all, we can waste time. And secondly, it's like, putting a microscope on a big picture when there might be so much more beyond that. So, what was the moral of this exercise and that video? Very simple, nothing complicated.
Listen to the patient, respect the patient,
Yes.
be empathetic,
Yes.
and don't be mechanical about it.
Yes, don't be mechanical.
Keep the patient informed.
Yes, and begin with an open question. Okay? Like I did with Priya, what did you eat today is a relatively open question compared to did you have this, did you have that, did you have that? Now, what could be a good open question that this doctor could have used? My favorite open question, especially with major illnesses, tell me from the beginning what happened. Okay? And then I listen for, sometimes it takes only a minute or two, sometimes it takes longer than that. And that way we get answers which we otherwise may not get. Let me just go back to my slides. I'll just keep it on this view rather than slideshow, if you don't mind. Can you still read it?
Yes.
Yeah, okay, so
Yes,
I'll just keep it on this because it shares it more easily. Huh? So we have open questions, we have closed questions, and in between we have focused questions. Okay? So even to take an example from the food example, an open question would be, what did you have for breakfast today? Okay. A focused question might be, how did you find your breakfast today? And a closed question was, did you like the puris you had for breakfast today? Let's look at a clinical example. Tell me from the beginning what has happened. We call this an open to close cone. And then if the patient says that I had breathlessness, what makes the breathing difficulty worse? Okay, so the what is still an open word, but it's focused over a particular symptom. And then this is a little more close. Can you walk till the bathroom? So for most things, if we start open and then cone down, we get better information. And when we start with the open question, like you said, listen. Okay. And when you listen, there are three things we listen to. Anybody can tell me what is I, C, and E in communication? Please, if you can just say it.
Information.
Okay, for this particular acronym, that's not the word, but the concept is there in this. So let's look at our next video. And
Be consent.
yeah. Okay. Okay. So what does this patient think? What did he know? He knew he had cancer. What was the problem? It was pain and scared, he says. What is he hoping from the doctor? That they will treat the pain without operation. Now, this business of listening for the ideas, concerns, and expectations, I have found tremendously helpful because with exactly the same disease in the same stage, in the same biopsy, patients may have very different ICEs. And that is what is, in a way, the beauty and the joy of medicine. Let me share one example with you. So we used to have the radiation oncology doctors rotating through the palliative care clinic, the residents. And we had one resident who always took a very detailed history, but like you saw in the first video, often it would be a checklist of questions. So I said, okay, the next patient, just let him finish saying what he has to, and then we'll fill in the gaps. So the man, he came in, he was a patient. When we looked at the notes, he had lung cancer with bone secondaries. And in my mind, my agenda is maybe I have to tell him he has cancer. Maybe I have to tell him it is incurable. Maybe I have to tell him the option of palliative radiotherapy. And maybe I have to give him painkillers. Anyway, patient comes in, we tell us from the beginning what happened. And he says, I developed cough. Often when we go to a doctor, with that first symptom itself, we interrupt, isn't it? When did the cough start? Was there any blood? Did you have fever? But wait, let him continue. Often he will tell you the story. One of you said the patient will tell you the diagnosis. I had cough. I went to the doctor. They told me I had cancer. So one agenda of mine is gone. He already knows he has cancer. They told me it was incurable. He already knows the prognosis. They told me I could have chemotherapy and radiotherapy. He already knows the treatment options. And then he said something which I didn't expect. He said, I work for a government company in Orissa. What I want to do is I want to go back and get voluntary retirement. If I get voluntary retirement, I'll get a good sum of money for my family. I want to settle them, and then I want to start my treatment. So his ideas, concerns, and expectations allow me to make a patient-centered plan. So what did we do for this patient? Actually, the main thing that I did was to give a letter saying that he has this diagnosis, he wants to take VRS, and if it is permissible, please expedite that process as soon as possible. Okay? And the patient was happy because we were able to meet his real need. And I have found that however old I have got, there really isn't too much of a substitute for giving a few minutes to listen to that story, because then it tells you about the rest of the roadmap. If the same person had said, they told me I have cancer, but I don't believe it, I've come here because I want you to tell me it's not cancer, then naturally my approach would be different. So let's continue with the video. So what is one thing which you might want to use?
Time given by the doctor to the patient.
Yes. Yes, sir. That's an important point, and sometimes we say we are short of time. But it's like when you're building the foundation of a house. If we don't give the time for the foundation, the 5 stories on the top can collapse. Okay? So in the critical consultations, if we give the time, it can, like in this kind of a situation, even be a matter of life and death.
Actually, the right treatment for this patient was going in for surgery. But because of his fears with his relative and all those things, and the cost and the bad experiences relative had, he was reluctant. But you did not force it upon him that you have to go for surgery or you'll die, and what nonsense. But you told him to take his time, but also told him that it is important that he take that step quickly and come back in 2 days. Like, you communicated the thing without being rude or that I know everything, and that type of thing.
That's because most people, we know the proverb, no? You can take a horse to the water, but you can't make it drink. So all that will happen if I'm either rude or if I don't meet him where he is that he won't come back to me. And his disease will become incurable. Whereas if he realizes that I'm on his side, I'm trying to understand why he's afraid of surgery. It's a huge decision. He's made up his mind, and I'm asking him to change his mind despite the terrible personal experience he has witnessed. So we're trying to keep the door open and asking him to think about it and asking him to come back after 2 days so that we can take the conversation further. Yeah. Now let's look at another video. Do doctors talk like this? Do we advise on treatment like this?
Mostly.
No, ma'am.
Not always.
No.
No?
Sometimes we use the jargons.
No. Sometimes we use jargon. Do we often talk fast?
Yes, ma'am.
Yes, we do. Now, if you're on the other side, if you're the patient, how much of this goes in? Not a lot. Now, the question I want to ask is why do we give information like this? What makes us do that?
We
There
always
may be
think
many reasons. Yeah.
we don't have time. We always think we don't have enough time. We have to hurry up. We have to finish so many consultations.
Yes. So time is an issue. Agreed. We spoke earlier about the foundation, and sometimes, often, if you can give people a handout that they can read beforehand, and then clarify things, that is one way. Sometimes, if you have a nurse educator, that's another way. Especially for critical things like this, we may have to look at ways in which we can make time. What about attitudes? What is the underlying attitude that promotes this form
The
of?
patient was also a professor, so he has to show off like things.
Right. Yeah, I think I like the word show off. Okay.
And pride.
Yes.
Kind of bossing attitude.
We have, if we're not careful, as we get our training and as we get more and more senior, a certain kind of professional pride can come into us.
Lack of empathy.
And here, yes, a lack of empathy, which comes for 2-3 reasons. One, this becomes routine for us.
Yeah.
For this patient, this may be their only cancer or their life and death. For this doctor, there are 15 patients, 30 patients he's seeing that day.
Ma'am, I'd like to
Yes.
add that this is a true practice. I'm a practicing anesthetist. This is true in the OT as well. Like when you have a patient who comes on the operation table, the patient is scared. But for the staff, the doctors, the nurses, it's something which they're doing every day. They have 10 patients and they have to finish. Everybody is doing their thing, but the person who's at the center of this it becomes mechanical actually, because so they don't realize that for him it's the only event, whereas for you it must be just one of the things which you do.
Exactly. Thank you for expressing that. It becomes mechanical. We can become rather confident of our abilities, our experience, our positions. And sometimes here, you saw the bit, it will advance medical knowledge, so you must take the full dose. He's trying a new therapy. So his agenda is more for that therapy to be optimally done. A little bit that buried agenda is there as well. So just as a little antidote to these things that can happen to us, that we lose our empathy, we become mechanical, we are focused on our agenda. Let's look at our last video. Shri Priya, could you share the empathy video, please?
Sure.
Instead of me wasting time again. I think that is the crux of it, no? Often it's worth asking ourselves, if I were this person, what would I want? And sometimes the light bulb goes on and you realize, I won't want to sell my house for this therapy, which may give me 6 months, even though it's so exciting. Or maybe I want to go back to my village rather than spend 80% of my time here. So as we go around our hospitals, curative, palliative, let's just try and remember that for the people around us, it is not just all in a day's work. To summarize what we discussed today, we said that communication can be a life-saving intervention. There are non-verbal elements which are important both in how we say things and how we watch the patient's responses. There are verbal elements, and an open to closed cone helps us to gather information more effectively. When we give information, to give it in bite-sized pieces and check what is understood before we go ahead, and always listen for the ideas, concerns, and expectations. Perhaps I'm a little over my time, so perhaps we'll have the case presentation and take questions along with that. Is that okay?
Dr. Sunil, do we have to confirm the same? Sunil, sir, you're muted if you were trying to communicate something.
Ma'am, I have a question with you.
Yes.
Ma'am, how do you protect yourself emotionally when you're handling very sensitive things you feel without getting entangled? How do you protect yourself?
Yes, I saw your comment as well. I think there is no complete answer, but maybe the few things I would say, especially if you're asking that question, I would feel that you are an above average empathetic person. Okay? So the few things that I found helpful, one was that actually when we get engaged with patients, in many ways it also is more rewarding because you're able to meet their specific needs. The second is if something is getting too much for you, then talk to someone about it, or even just get away for 5 minutes and take a break before the next. Some people just do a brief 2-minute mindfulness breathing exercise between two difficult patients. I personally found it quite helpful to write patient stories. Sometimes look back and see what positive things you've been able to get, and also have some boundaries. For example, for me, if I was not on duty on a Sunday, I would try not to think about my patients. Have a life outside work, your children, your hobbies, your family, gardening. I think it's very, very important to have some creative or emotional outlet because that puts the endorphins back in. But there is a cost, and I have experienced that, and I know some very, very senior people in palliative care have experienced that as well. But at the end of the day, generally the worthwhileness and the satisfaction outweighs the pain.
Yes, ma'am. Thank you. That deep breathing, I think I can try. And writing down, even after you told, I think whenever I write down, I feel something, I have completed it off and I've given a closure to it. Now I can move on to the next part of my day. Maybe I'll try it regularly.
Yes, I did find that helpful. And occasionally even a question like, what am I learning from this patient? That was also another question I found helpful.
Excuse me, ma'am. Ma'am, could I ask a quick question?
Yes.
Ma'am, not often, but the few times when the stories from the patient are so distressing, and especially when it involves a pediatric case, and it's helplessness all are over, and your hands are also tied, you don't have any means to support that patient. in terms of your hospital doesn't have any social work support or anything of that sort, no schemes eligible, stuff like that. And, I see myself often tearing up. And then I get very conscious because I'm not supposed to. As a doctor, I should be toughening up. So is that a normal reaction, or does that happen even to the biggest and the most experienced?
Yes, I think any doctor who has a heart, if he's in the kind of situation you describe, that happens. It has happened to me many, many, many times. In fact, I remember Dr. Rajgopal telling me that, like him, I also had a leaky tap. And I remember when I spent a year with Dr. Twycross, and I remember him telling medical students that he has cried many times. Okay, so I think it's probably a good sign.
That's very, very good. I've wanted to know, get this answer, hopefully, from somebody senior, because I often find myself rushing to the washroom to hide those tears, or doing some deep breathing, or covering it with a mask or something of that sort. Yeah.
The majority of families would actually be touched and grateful that you felt for them. Okay, so you don't, just if you have tears in your eyes, you don't have to feel embarrassed or hide it, is what I would say.
Thank you, ma'am.
Thank you for that question. Yeah, for both the questions.
Madhavi? Good evening,
Yes.
everybody. Ma'am, that was a very wonderful presentation, and the last video was really touching. So,
yes, I love that video. Yeah.
I'm Dr. Bhargavi, working as an assistant professor in Vaidehi Institute of Medical Sciences in Bangalore. So this patient is a retired bank manager, a male, also a very close family friend of mine. He's 64 years old, and his diagnosis is transitional cell carcinoma of the left distal ureter, T3N1. So he presented on 7th April of 2022 with nagging pain at the left loin since a week to 10 days. He presented to the surgical OPD in a nearby hospital. The pain was, apart from being nagging, it really wasn't affecting him much. It was localized to the left loin, increasing only on lifting weights and on brisk walking. It was relieved by taking over-the-counter pain medication. So just because his wife kind of told that let's show it once to the doctor, so they went to the doctor. It was a dull aching pain not associated with any other symptoms. So the doctor who examined him referred him to a urology center, as he felt that the issue was kidney related, and he was advised renal function tests, ultrasound, and a CT scan, pain and contrast. Mostly they were suspecting obstructive uropathy, so pain and contrast of the abdomen and pelvis. So the ultrasound and the pain CT suggested probable stricture or calculus with left hydrouretronephrosis. And this entire process of getting investigations done was done at a nearby laboratory, so on appointment basis, which took a week's time. But by that time, he started developing fever with chills, and slowly the creatinine values went up from 0.8 done on the first day to 2.5 done, I think, around 7 to 10 days later. So the oncosurgeon, the uro surgeon who had been the urologist who had been referred, who had been recommended to them, he insisted on a contrast CT. So the problem started from there, where the CT scan center refused to do the contrast CT because of the rising creatinine values. So a week later, that is on 15th April, the urologist insisted on the contrast CT again, and the scan center refused the CT scan, and the surgeon and the CT scan in charge, they both had a verbal altercation in front of the patient. Finally, the CT scan center's head had to come, and he had to settle the issue. The center's chief nephrologist came, and all this happened in front of the patient, with the urologist actually fighting collar to collar with the CT scan personnel. So finally, after the intervention of the nephrologist, the urologist decided to go ahead with stenting the ureter letting the creatinine come down and then going ahead with the contrast CT. So during stenting, he told the patient the surgery was done under spinal anesthesia. So he kept speaking to the patient. He took brushings of for cytology and biopsy, and he also said that it looks more like a stricture, nothing much. He asked for follow-up once the serum creatinine came down. Now, during the entire procedure, the surgeon was very abusive towards the OT staff, the nurse especially, which was constantly observed by the patient. But he was of the he's of the generation who believes that the doctor is next to God. So he just mentioned it to me, but did not take it forward. So this biopsy of the brushings that were taken was negative for malignancy. The creatinine came back to normal around 0.75 in again a week's time. And then the contrast CT was done. So this contrast CT, they suspected transitional cell carcinoma of the distal ureter or left ureter. But when we saw the diagnosis, the patient immediately went to the doctor, showed it to him, and he said that as a doctor, I know better. So he said that he has visualized the interiors of the ureter, and to his trained eyes, doesn't look like a malignancy. So just leave it there. So during the entire course of treatment, this doctor never tried to develop a good rapport or a good patient-doctor relationship. Now, the patient was not at all comfortable with this doctor, and he expressed it to me many times. But because he'd been recommended by so many people, so many of my colleagues, so we just went ahead with the same doctor. Next. So now we had a doubtful contrast CT. We thought we'll take another opinion from another uro-onco doctor. So who was from an exclusive onco setup. Now the whole issue was explained to him in detail, and we repeated all the investigations again. And everything was unremarkable. And the CT scan again, which was done, showed that there is a stent in situ. So restenting with a bigger stent or ureteric reimplantation as need be was the next plan. So on 4th of July, this is almost around 3 months later, after the first symptoms developed. So the scopy was done again, and the surgeon was shocked to find multiple small malignant tumors in the distal ureter. And as soon as he saw them, he came out and informed us that it is very probable that it is malignant, and he would require a radical nephroureterectomy with excision of a sleeve of bladder with retroperitoneal lymph node dissection and a peritoneal lymph node dissection. So once this stenting, and the stent could not be taken out because of those tumors, so he left the stent in situ. So after this surgery, he called the family for discussion. So he told us that all of the people who have a say in the patient's treatment were to be present for the meeting, and he was willing to clear all the doubts. So as promised, the next day the meeting was set up. He took almost an hour and a half to explain to the family. He explained the pros and cons of each of the procedures that can be done next. So what happens if chemo is done first? What happens if surgery is done first? Or so he drew an algorithm. He explained the outcome. He allowed all of us to ask our questions. And there were people among the relatives who were not did not have a medical background, and they asked sometimes really silly questions, but he did not get angry. He answered each one of them with utmost patience. So he, at the end of this discussion, he also said that you can take these papers in which he had drawn the algorithm for a second opinion and revert back if we were satisfied with his course of treatment. So at last, the final course of action was planned, and informed consent was taken after we took one more opinion from another doctor. So 12th of July, the biopsy report came, and it showed a positive report for CA left distal ureter. So finally, on 17 July, that is 3 months after the initial symptoms, a definitive robotic procedure was done. Once done, the patient was prepped up for chemotherapy as one pelvic lymph node was positive for malignancy. It was considered metastatic. So right now, he has completed the final session of chemotherapy after a lot of ups and downs through the procedure. And now he's eagerly looking forward to leading a near normal life again. So now he's extremely comfortable with the second doctor we went to, feels he's really God sent. and the doctor is always available to take calls. If he's not available in a surgery, he'll inform through a message, and he'll inform the time at which he is available for talking. He's available for counseling at any time. He takes the time to answer all the doubts the patients or relatives ask. Though he's actually right now not directly involved because the patient is now under medical oncology, but still he is answering every query with utmost patience and dedication. Now, the current issue that is troubling the patient is that he's worried about who will take care of his wife if anything happens to him, because both his daughters are settled abroad and they have their own lives to cater to. He's upset that he's never been bad to anybody, so why has God been unfair to him? We had considered reference to a psychologist or a psychiatrist because during the course of chemotherapy, he had almost clinical depression, which required counseling sessions. And it had led to a drastic reduction in food intake. He had a weight loss of almost 10 to 12 kgs in 2 months. He had electrolyte imbalance because of the same thing. He had to be admitted twice. Now the surgeon has been in touch with him constantly, encouraging him to eat well, sleep well, don't stress out. So just like a friend. And when he was admitted in the chemotherapy ward, most of the patients in the ward had good words to say about this surgeon. So everybody used to say that he's, if not God himself, he's just really God sent. So what this patient says is that the most important thing a sick person needs is compassion, tender loving care, and the hope that all will be okay after some time. So somebody who listens to him, to the procedure plan, is what he wanted and what he got from this doctor. So instead of scaring him with untoward consequences, explain the details to the patient. This doctor explained the details of the patient and the relatives, and especially when these were well educated and they had prior and they took a well informed decision. Now the doctor in this case, he followed all the principles of palliative care. He counseled the patient. The disclosure of diagnosis also was done initially to the relatives. Then after speaking to them, slowly it was disclosed to the patient in their presence. The plan of action, then the course of action for chemotherapy first or surgery first, giving the choice to the patient about the final course of action. Everything was done by the doctor. So the patient felt that he had been given respect in choosing the course of his treatment. The patient feels involved. He feels that there is truthfulness and transparency in the way the surgeon has taken it, and the way the treatment options were given, and the prognosis, the way it was explained to him. So counseling was done well. Physical, psychosocial care was taken care of. The doctor also, they are almost at the same age, the doctor and the patient. So they discussed a lot of spirituality. So they had no issues in communication with the patient or the family, and there were no ethical issues. So compared to the first doctor, the second doctor, uh, followed all the principles of palliative care that have to be actually followed. So inculcation of palliative care concepts at so what I want to summarize with this presentation is that we have to start inculcating the concepts of palliative care at undergraduate or at least the postgraduate level, so that we are not so inhuman when it comes to putting forth a diagnosis at the patient, which was what was discussed just now in the class. So we should, learn to empathize with the patient, give some time to the patient, and the need for involvement of palliative care should be stressed at each point, in case the patient requires, because when he's going through a process of treatment for a condition that he's not mentally prepared for, he'll require a lot of support. Next. Yes, ma'am. So the communication skills, principles of palliative care, involvement of the patient and family, and what if the patient or family is in denial are the points that have to be concentrated on for discussion of this case. Thank you.
Thank you, Dr. Bhargavi. That is an excellent presentation. And you have brought out how, the principles of palliative care naturally are not just at the end of life, they're a part of good medical practice. Good communication and good symptom control will improve outcomes, whether it is diabetes or whether it is cancer. And the Parliament team is actually more than anybody else trying to integrate these principles in nursing and medical courses at an early level. Your presentation also showed some of the things that we discussed earlier. You see the pride in the first doctor. He cannot bear to be proven wrong. He's even willing to fight when it will be harmful to the patient by saying that you should do the CT now, that this is not a cancer, I know what it is. That kind of pride is dangerous, and we all have to be aware that we are at risk. We can also see that even the most uneducated patient, this patient is educated, but even the most uneducated patient can sense that this is not right, that this kind of behavior is wrong, and you lose trust. We also saw the point that early in the relationship, when critical decisions have to be made, time is needed to make that foundation. And patient-centered decision making usually leads to better compliance, better choices, and lesser litigation. Okay? Because you've made that choice understanding the pros and cons. So it's a beautiful illustration of contrast. I think the one point that we had not discussed and also, the point of bringing in important family members who are involved in decision making. Remember, I started with the story of the interpreter not communicating to the family. The question of what if the patient or family is in denial? So here, are you talking about denial of incurability or denial of diagnosis?
Ma'am, denial of incurability.
Yeah, that is the more common one. Now, in general, denial is a protective mechanism because I can't bear the truth. Okay, and so one has to look at the benefits and the burdens of addressing that denial. Now, if somebody is denying incurability, but at the same time, he's thinking, what should I do for my children? How do I settle my affairs? Then at one level, he's doing what is necessary. And I may not need to, at that point, bombard him with more information. I may say, do you want the details about the prognosis or do you want to discuss that later? And I might explain the details of the prognosis to a close relative who is in a better position to take it up. But on the other hand, if the denial is making him do things that are harmful to him, either by saying, okay, now I'm going to start a big loan and start a new business and show my doctors what I can do, these people who are giving me this bad news. Or if they're saying that I don't mind taking 1 crore for the next treatment, I know that I will be the one who's cured, then the denial is being objectively harmful to them. Sometimes in such a question, the couple of questions that I have found helpful, one is to ask them again, what are you hoping for from this? And then you identify the communication gap and you try to you acknowledge that, okay, I can see that you're hoping that you will be the one person who would be cured. But suppose you were the 90%. So the suppose is a useful word. Suppose you were the other way, then what would happen to the family if we went down this route? Or so, similarly, I know we want it all to be cured, but if suppose a friend of yours had an incurable condition like this, what would be the most important things that he would need to do for his family? So sometimes these people are willing to consider it in an imaginary context. But what I would say is that if there is no immediate danger, give the person a little bit of time and communicate it with a trustworthy member of the family, and then revisit the question a little later. Okay, we have to tread a little carefully, weigh the benefit and the burden of breaking the denial then and there fully. So I think we are close to our 7:30 time. Thank you all.
Madam, there is a question in the chat.
Yes.
By Dr. Karishma. She's asking your opinion of informing the prognosis of the cancer upfront instead of waiting to be asked about the prognosis by the patient.
Right. Yes. I think what I would say is, and somewhere in my Small Things Matter video, I had a line saying dialogue, not monologue. Okay. So when if, for example, it's the first visit and you have told him the diagnosis, different patients react in different ways. So the second part of that, follow their lead. If somebody is so shocked that he can barely believe the diagnosis, then the discussion on prognosis may be better done at a second visit. If somebody says, they will take the lead. Some will say, is it curable? What should I do? If I take this, will I be cured? So be guided by their question, give a bit of information, observe their reaction, give the next bit of information. That's my general policy. If time is short, like we have patients who come from far away and have to make a choice, then I might ask the patient, see, we're going to discuss your reports. Do you want all the details, or do you want me to discuss with a member of the family? And then if they're hesitating, sometimes I may say, some people say that if the reports are not very good, they don't want all the details, just to discuss it with the family. So that gives them an opt-out. And on that visit, I may discuss with the family and tell them you can discuss it later. But if people have to make an expensive or critical decision, then they need to know the prognosis before they make that decision. A fool's hope, taking unnecessary toxicity, unnecessary cost with a misguided expectation, there will be regrets later. So I'm sorry, I've not given a yes or no answer. Again, it's a question of benefits versus burdens. If they don't know now, will they make a major mistake? Is this person able to cope with it today, or is there a better person who can cope with it today and this person later? We have to individualize it. Follow their lead, watch their reactions.
Thank you, ma'am.
We can take one more question if anybody has anything to ask.
Ma'am, in your experience, how many patients would like to know about their diagnosis or prognosis in our Indian setup or South Indian?
Yeah, in my experience and also in surveys that have been done from India, it is no different from the West. About 80% want to know. And even those who don't want to know today, usually sooner or later, they want to know. I would say that maybe it's only 5% who never want to know. And actually they know at some level, they just don't want to acknowledge it. It's like, if you've done an exam badly, the results have come, everybody is discussing without telling you, you kind of assume the worst, isn't it? And then after a while you think, might as well know instead of imagining it better, instead of imagining it
And when the family tells you that let's not tell to them now, so this happens usually, is that's very common, right, ma'am?
Yeah, it is common, and I'm guessing it will probably be covered in your next class on communication. Will that be Dr. Sunil, collusion?
Yeah,
Or
yeah.
should I?
Next session we have pollution, communicating bad news, and how to handle
Right.
emotions.
Okay.
So there, I think there's quite a lot there which will come up. But the short answer is that if the patient wants to know and the family says don't tell, the patient has a right to know, but we need to negotiate with the family, and especially in our Indian setting, because it's the family that often funds the treatment and brings the patient.
Okay.
If we totally ignore everything, they just may not bring the patient back to you, and he may not even get treated. So I think in the next session they will probably take that up. Yeah.
Sure.
So regarding how many patients would like to know, recently there was a paper from Tata Memorial Hospital where they survey, I think they looked up more than 1,000 patients from different states, and most of them have expressed that they would like to know more than 90%. But at the same time, when this question was asked to the family, only 25% of them would like to tell the diagnosis and prognosis to the patient. So that's how the situation is. Patients would like to know. But when you ask the family member, most of them would like to. Actually, it is a mechanism of protection of the family members from us, from the doctors and the healthcare professionals. So that's the controversy. Or yeah.
And these were the same statistics around 2005 or 6 from Calicut. 80% patients wanted to know, only 20% of families wanted to tell. One tip which I found useful, at least when I was in oncology, is before the biopsy to ask the patient, when the reports come, do you want to know, in front of the family? So then when he says yes, then it's a little harder for the family to say don't tell later.
Okay. So I think our time is up. So I would like to thank Dr. Reena for this excellent session on basics of communication, and also Dr. Bhargavi for presenting patient story, which was also excellent. And I hope all of you understood the basics of communication through various videos that Dr. Reena has showed us. And thank you, everybody, for your active participation. Supriya, it's over to you.
Thank you, Dr. Reena, for that wonderful presentation. It has always been our pleasure listening to your classes, and each session brings in at least one new knowledge to our team as well. So today has been no exception. Thank you for that, and thank you everyone for making this session also interactive. And hoping to have another interactive and wonderful session as communication 2. This is Sri Priya, along with Dr. Reena George and Dr. Sunil Kumar, signing off from the Tips Eco Hub. Till we see in the next session, everyone, take care. Bye-bye.
Thank you all. Thank you very much.